It is my great honor and absolute privilege to introduce our keynote speaker today, Dr. Robert Echenberg, who is also known as Dr. E. He is an author. He is the founder of the Echenberg Institute for Pelvic and Sexual Pain, located in Pennsylvania. He also treats patients in New York City. He'll share most of his story. It's also important to point out that he's a founding board member of Bridge for Pelvic Pain. Very, very excited to introduce him today. And with that, I hope you guys enjoy the day. We are going to take a lot of time to introduce every speaker, but we will do that for Dr. E. Welcome.
Thank you. Can you hear me speak pretty well? Mm-hmm. I have a little mic on here. We didn't test it, but okay. My voice carries pretty good anyway, so I just want to make sure you can hear me. Yeah, that way. So thank you, Karen. This gestational age of Bridge for Pelvic Pain goes back a little more than 2.5 years. I think more like 4 to 5 years when we first met. Karen interviewed me, and then we came to a program that I was involved with on the East Coast, and we met, and the gestational talk about doing this, having some kind of nonprofit organization to raise awareness, raise educational thoughts, and between doctors and other practitioners and patients. So it's wonderful to see, it's very rare to see actually patients and doctors in the same room. And the doctors that are here, I spent some time yesterday meeting several wonderful people that you're going to hear today as well. So I do hope you get a lot out of it and take part in it actually later in the day. So as far as talking about an overview, we're going to talk a lot about, how do I do the, sorry. There we go. I'll use this. Okay. So we're starting off with many, many people that feel like this a lot of the time. And I say people, not just women, but male patients as well that I see. And in the female, we all are familiar, probably since middle school, of the drawing of the pelvis, which I'm going to show you in a couple minutes, is totally inadequate and actually inaccurate. But it misleads so many people about what is the cause of their pain in the pelvic region. If you think about the pelvis as a regional part of our body, it's the busiest part of the body, both functionally and activity-wise, structurally-wise. So between the belly button and the mid-thigh is the pelvic region. 20% of all American women experience chronic pelvic pain at some time during their lives, mostly during their reproductive years, anywhere from puberty to menopause. So our patient population is mostly younger women, bell curving somewhere in the 30s to early 40s. But I see quite a few teenagers and people in their 20s, which I really enjoy, because so many people can be prevented from becoming the hopeless, helpless folks that we all talk about. The younger, the better. But any gynecology office, any urology office, any family practice office for that matter, that sees maybe 15 or 20 people a day, again, these are women, at least 3 or 4 of those people during that course of that day have many of the issues that we're going to talk about today. And most of them, the issue will never come up, the subject will never come up. Most of them are under the radar, most of them are starting to be little problems. We were just having a little discussion here a few minutes ago about the 15-year-old young woman who is doing 2 sports, having cramps, going to the school nurse with irritable bowel issues, stomach aches. She probably doesn't tell the school nurse that she can't put a tampon in easily. She's got lots of little aches and pains from the sports that she's doing, and she's being sent around to urologists because of supposed urinary tract infections and vaginal infections to the gynecologist if she's old enough to go to a gynecologist. Even the pediatricians are seeing some of these fits at age 12, 13, and 14. So what are we talking about? Pain in general, and I'm going to say in a few minutes how this took 15 years for me to totally really understand what I understand. And at dinner last night, or lunch yesterday afternoon with some of the physicians that I was talking to, we do realize that we're just at the beginning of understanding our brains and our nervous system and the neuroscience of all of this. So pain is the most common reason that patients seek medical attention, the leading cause of disability in the United States alone. Despite its prevalence, over 100 million people, only an estimated 1 in 4 are receiving optimal treatments, if that. So pain sufferers are not only victims of the pain itself, but of the system, not really keeping up with the ability to both talk to, listen to, and understand their symptoms. Chronic pain costs our healthcare system more than cardiovascular disease, cancer, and diabetes put together. And you'd think there'd be a little bit more research and a little bit more emphasis on trying to figure all of this out. In 2001, after a history of 30 plus years as a gynecologist, this became a birthing of a new program for me. And this is 15 years later. Overnight success generally takes about 15 years, whatever endeavor you're doing. And how did I evolve my practice into an entirely new model of care for chronic pelvic, genital, and sexual pain? It's obvious that over 30 years I was seeing many of these folks. Was I missing them? Yes. Was I even aware of them? No, most of the time. Was I confused with a lot of the patients that I was seeing? Yes. Was I sending people to various other practitioners and specialists? Oh, yes. Were they having lots of emergency room visits? In many cases, were they having lots of surgeries? In many cases, yes. And many of the people that had acute problems, I was taking really good care of as a gynecologist and not really seeing and being too concerned because most of my patients were getting better, but not realizing that 15 to 20% of them probably were going elsewhere and I never knew about it, and ultimately seeing sometimes many different specialists. We talked about this yesterday at lunch or dinner. There are no certified fellowships or residencies in chronic pelvic pain. There's many interdisciplinary barriers to that, and much talk about that among the people that are involved with chronic pelvic pain at the professional level in various organizations. But it's not going to come about very easily, if at all, in the near future. There's just too much overlap and too much politics to put different specialties together. I'm talking about medical specialties more than I am about other modalities that you're going to hear about today. Because the ideal, I think, is you're going to hear some of it today. Doctors should be aware of what patients are doing and what all of the other modalities that you're going to hear today are doing as well. So we need to work together. The International Pelvic Pain Society was established in the 1990s, and most of the gynecologists that I speak to when I do speak, either like this or person to person, haven't heard of the IPPS. I started going, I think this was in 2003 or 2004, and most of the years I did attend and learned a great deal about pain itself and from other specialists who were working in areas of pain management and other things that I had never been trained in as a gynecologist, and that they're still not training most of the gynecologists and urologists and GI doctors in. So I joined the International Association for the Study of Pain so I could get a pain journal on a regular basis. The American Pain Society is the American branch of the International Association for the Study of Pain. I think 80 or 90 countries are members of that worldwide global organization. They have a national or international meeting every 2 years. This year it's in Japan. A little difficult to get there, but people come from all over the world. And when I show people that there's an actual journal on pain science itself, they're surprised. Pain itself is a science. Most of you understand that there's a neuroscience to this. Most of you patients and the doctors are in here and talking to the choir. But in general, pain is looked at as a symptom and not as a diagnosis itself. And then in 2004, I wrote an article in one of the journals that we have, Contemporary OBGYN, about my program, a program for management of chronic pelvic pain. And then in 2005 to 7, collaborated in writing the book that's over there, Secret Suffering, How Women's Sexual and Pelvic Pain Affects Their Relationships. Took about 2 years with a woman who actually, Susan Billheimer at the bottom of the book here, is a patient herself, just like you heard Karen, in Florida. And we did a lot online together. She wrote parts of the book, she interviewed lots of people. And I still think that much of what we wrote in here is pertinent today and will be pertinent for a long time to come. A year or two later, I was asked to write the foreword for this book. I really highly recommend. The Proactive Patient Managing Interstitial Cystitis, Bladder Pain Syndromes, and Related Conditions, including pelvic floor dysfunction, vulvodynia, chronic prostatitis in males, irritable bowels, fibromyalgia, and more. Written by Gay Sandler, who is a patient herself, and her husband, actually. In 2015, very proud to have worked with 3 other folks. I'll picture there, put together, took 4.5 years to put a 4 DVD set together, and I think there's some in the back there that will be either raffled off or yeah. In the last few years, involved in helping to establish the first nonprofit to raise awareness, and here we are. So kudos to you, Karen, and all the volunteers. So most physicians are still not being trained in up-to-date neuroscience and its application to chronic illness and chronic pain. There's dysfunctions, they're not being trained in dysfunctions related to or influencing sexual function. They're not trained in integrating the biopsychosocial approaches to chronic illness, not being trained in working in interdisciplinary teams, and not being trained in mind-body applications of healing. And I'm sure everybody in this room understands that each one of those is extremely important for doctors and patients to start talking the same language to each other and not having a disconnect in almost all of those areas. Our program for pelvic genital and sexual pain, we have seen approximately 1,400 patients in the last, I would say the last decade. I opened up my own practice after starting this program at a community hospital in eastern Pennsylvania. I think the practice started in 2006, so we're now at a decade. Patients have come from 31 states at this point and 9 foreign countries, which is a total hard thing to understand, why people have to travel that far to get what often are simple, basic, straightforward treatment plans, but that still seems to be the case. Each fills out an 18-page questionnaire before being given an appointment. I have a male and female questionnaire that I forgot to take out of my little briefcase. I'll leave it for people to look at one of the desks up here, or put it over there where the books are. And it's something you can go to our website and actually download, and just filling it out is helpful to show your own physician or own physical therapist or own nutritionist or whoever you're seeing, because there's lots and lots of things in there that are quite comprehensive for caregivers to understand about your background. I then this is the part that I really can't recommend for other physicians, because I know it's not going to happen. I do spend 3.5 to 4 hours with each new patient. So all of those 1,400 patients I have spent that amount of time with and develop a rather complete report. And that then can be their ticket to giving to other physicians, other caregivers, and an explanation, and finally diagnoses that make sense to them. The model that I use, as I talked to several people yesterday at lunch, does not have to be a doctor doing most of that 3.5 to 4 hours. It can very well be a PA, it can very well be an NP, or or even in some cases, medical assistants can be trained to understand the concepts that we're talking about here. And the doctor can do the other parts and come in for the treatment modalities. The reasons for success in our program, I believe, listening and believing, big, spending enough time over a period of time, biopsychosocial approach, education in the new neuroscience and chronic pain processing, explaining pain. I put that in quotes because there's a huge growth of information coming out of Australia, of all places, from manual therapy people, that I'll mention in a little while, to explain to the masses, so to speak, what the neuroscience has exploded with in the past 10 to 15, 20 years. Looking at pelvic pain as a chronic regional pain syndrome, I was pointing back here to the slide from before, between the belly button and the mid-thigh pelvic region, and there forever we've had regional pain syndromes, and some have written about pelvic pain as a regional pain syndrome, which crosses over many disciplines, of course. And knowing the total anatomy and physiology and function of the pelvic region, and maintaining a sense of safety and compassion throughout the course of diagnosis and developing a treatment regimen. As well as continued reminders to each patient that all of us are wired to protect ourselves. That's really important to remember. When you're feeling like you hit bottom, your body is still working as hard as it possibly can to renew and refresh and heal. And the wisdom of the body to heal itself has to constantly be reminded to reboot. And the rebooting process in the midbrain, which is our protective part of our brain, needs to, you as an individual, your intellectual thinking part of your brain, your cortex needs to understand that what it's being told by your midbrain on a constant basis really has to do with all the cumulative memories of your entire life. And that midbrain is there to protect. It, however, remembers also all the good things. And we all know that at any one moment you can hear a song, you can taste something, you can hear something on music, you can smell something. And it takes you immediately back to a point in time that you would never think, why am I remembering that at this moment? The midbrain is there to do all that for us. We wouldn't be able to be gymnasts. We wouldn't be able to have an Olympic village over here without, or play the violin or the piano for that matter, if it wasn't for the muscle memory and nervous system memory. So that's all the good parts that the midbrain does in our nervous system. But it also remembers the bad stuff and cumulatively builds up over time with many routine and often very healthy things that we do in our life. Looking at you, an ex-athlete, or continue trying to be athlete. And also we incorporate simple, minimally invasive office procedures that actually reduce pain and lower the visceral and somatic triggers of pain or danger signals emanating from the pelvic region. There are a few cards that I have left over here, but on our little brochure from my practice, common diagnoses, IC, vulvodynia, vestibulitis, pelvic floor dysfunction, pudendal neuralgia, pelvic endometriosis, of course, because I'm a gynecologist to begin with, but I actually don't treat very many people anymore for pelvic endometriosis because, number one, I'm not doing surgery anymore, and my program is totally non-surgically oriented. And number two, most people with endometriosis ultimately do get treated appropriately because that is emphasized in gynecology. So as we speak, there's sometimes symposia going on elsewhere in New York and all through the country, from the American Association of Gynecologic Laparoscopists, for instance, and they get 500, 800 people attending, doctors attending those conferences. Some of those people would be well to hear some of this stuff, but we also have to appreciate that the surgical stuff that they're doing is unbelievably good, except not if it's like the patient I had who had 13 laparoscopies for her endometriosis and was sitting in front of me with the worst pain she's ever had because it wasn't the endometriosis that was causing her pain. Almost all of my patients first go to Dr. Google and stay with Dr. Google during the course of seeing 4, 5, 10, 15 different specialists. And Dr. Google is always there for them because you can find anything in that office. But you're doomed to unrelenting lifetime pain and suffering and possible suicide by going on to any of those subjects if you Google, and I'm sure some of you know what I'm talking about. And that's not a good thing. There's tons of good things online, including Bridge for Pelvic Pain and many other organizations, the National Vulvodynia Association, the Interstitial Cystitis Network and the Association, all these really good resources. But when it comes to patient forums, some of them are excellent, but some of them are just, in my opinion, causing more heartache and more hopelessness. Some recent examples of my own patients. Whenever I give a talk, I try to just go back to the last month or 6 weeks of patients that I see, because I have a continuum of very similar types of examples. So one of the pages in the third page in my questionnaire is drawing where your pain is. And I think every doctor and every practitioner who sees people with pain should have them draw their pain before coming to see you, so that it tells you actually what part of their body is really hurting. And at the top of the page, we say draw everywhere in your body where you have pain, and put X's on the particular spots that are most difficult. So you can see here already that the entire vulvar area is blackened out, and the lower back and hip area. And this part here is like picturing the inside of your pelvis. This person says the entire inside of my pelvis is in pain. So she was told severe stage 4 pelvic and abdominal endometriosis and adhesions, diagnosed by nationally prominent GYN MIG specialty, that's minimally invasive gynecologic surgery specialist, with 2 laparoscopies in 2011 and 13. She was never given a diagnosis of IC, even though the Huff scale score was 23, which I think you'll understand that better through the day to day. That's a significant indicator of painful bladder syndrome, a Huff scale score of 23. She was never diagnosed with it, however. Also has IBS and severe vulvodynia. This, by definition, is vulvodynia. Vulvodynia just means pain. Dynia means pain in the vulvar area. So, controversial as it is, different people feeling different things about what vulvodynia is and the causes thereof, it still is pain in the vulvar area. I think the term vulva should be discarded because there's no 14, 15, 16-year-old girl, or boy for that matter, that even knows what that term means. Okay, and you ask a young woman about their vulva. My father has my car. That's my father's car. Okay. So vulvodynia is confusing to everybody just because of the term itself. But nonetheless, when people draw, that's where their pain is. That is very helpful to us. And I think sometimes the people that are doing all the laparoscopies, if they just saw a drawing like this, would realize that doing a scope and whatever surgery you're doing internally is not going to help that very much. 23-year-old male from Minnesota, serious sitting pain, post-ejaculatory pain, 10 plus practitioners over 2 years, some of whom said, it is in my head.
He said, sex is bittersweet. I will never improve. I will quit my current job. Years of baseball, snowboarding, and skiing, and other traumas. You can see where he drew his stuff. He, by the way, is not a new patient. From last October or November. Seen him twice now, and he's remarkably better with good physical therapy and treatment for IC. 48-year-old female from Pennsylvania, severe proctalgia, meaning rectal pain and spasms, and severe vulvodynia, undiagnosed, by 15 plus. So one of the questions is, how many doctors do you think you've seen? So she put down 15 plus providers over 3 years. 3 rectal surgeries for Fisher over 1 year, 15 years of hiking, dirt biking, weightlifting, water and snow skiing, which no one ever had asked her about. Vulvar straddle injury, which was significant in her memory. And at the time I saw her, unable to sit, completely incapacitated, isolated, depressed, and suicidal thinking. Doesn't look like she's drawing too much, but she couldn't sit through the entire session. 29-year-old female from New York, 9 providers over 10 years, widespread pain and migraines since childhood, 5 sexual partners. The first intercourse, however, at age 26 with her last partner. Now she's alone and fearful of relationships, never able to use tampons and get a pelvic exam, long-term sports and traumas, and said she was told by a physician, if sex hurts, then find a partner with a smaller penis. And women who regularly masturbate are more likely to experience pain. Among many other things that I hear patients say to me. When you actually listen to patients and they trust you enough to say some of those things, you hear them. The last one, persistent genital arousal disorder. If we have any time today, I'll talk about that briefly. Saw a nationally renowned urogynecologist, never mentioned vulvodynia. Look at the vulva there. Never mentioned it. And she was told this is a lifelong problem. You're just going to have to work up slowly to be able to sit for 2 hours at a time. And a neurosurgeon gave her spinal blocks that did nothing. And our treatments down here representing some nerve blocks, dental blocks, trigger point injections that totally take about 10 minutes to do. And the person can get up and sit for the first time, say in 5 years, and feel like they're floating because just local anesthetic to release the trigger points and to bring down the pain where the neuropathies are going on. And they've been told there's nothing you can do to alleviate this pain. Well, yes, it's temporary, but no, it cannot be just temporary. It goes on and reboot the peripheral sensitization, which we're going to talk about. So our typical complex of pelvic pain patients, urinary frequency and urgency, irritable bowel issues, lower abdominal bloating and pain and pressure, vaginal itching, burning, and sensitivity, genital pain, burning, and itching, sexual pain, entrance, during, and or after, and lower back and lower abdominal pain. So I showed this picture, this handout to people near the beginning of their session with me, and they say, how did you know? How did you know me? Not everybody has all of those, but each one of those things are common to begin with. And you put them all together over a number of years, those are symptoms that are out there, and you guys know it for sure. But I said before that there's 20% of the population of females at least have combinations of these symptoms over long periods of time. So it turns out that there's about 30 million women in the United States alone, by definition, having chronic pelvic pain with those symptoms. And they've seen all the list of these docs, for the most part, including the psychiatrist at the bottom. And all the docs are arguing with each other. The gynecologist and the urologist and the GI doctor all are giving this patient or the family different answers, different advice, And it's no wonder that you would go to Dr. Google following that. They're also getting ultrasounds, MRIs, CAT scans, colonoscopies, cystoscopies, other laparoscopies, surgical removals of various structures, including ovarian cyst problems, adhesions, endometriosis implants, and even hysterectomy. These are the patients I've seen who are coming as what we call complex abdominal pelvic pain syndrome. And they're no better after having all these things. Each of those things are extremely important to have in our armamentarium as physicians. And most people, 80% of us, get better because of this technology and all of the newer technologies that are, including robotic surgery and all the other amazing things that we're doing. But what about the other 15 or 20%? After getting all those things, how much money has been spent in the system doing those things over and over and over? So we say our program keeps people out of the emergency room, keeps people generally out of the operating room, and keeps people out of the psych ward, for the most part. All three places that most people would rather not be if you don't have to be. And the hysterectomy part of it, the youngest person I've seen with a hysterectomy was 21, and then I've seen a number of people who were told in their teens that they either should have a hysterectomy or wanted one because it was indicated to them that's the only way we're going to be able to fix your pain. But we can't do it because you're too young. I also have a 28-year-old young woman who wants a hysterectomy, and I believe she should have a hysterectomy for the endometriosis that she has. But she's on her 9th laparoscopy, and the doctor keeps telling her, you're too young. And she says, I don't want children, I am completely informed, and so it works both ways sometimes. Difficult to have these issues. So some of them come in and say, I hope you're not going to be like the other 20 incompetent doctors who couldn't find anything wrong with me. So where I'd like to take you is away from the gynecologic stuff that I had learned. Again, endometriosis, ovarian cysts, pelvic adhesions, pelvic inflammatory disease, congestion, severe dysmenorrhea, towards looking at these pictures in women at least. Gynecologic triggers, urinary bladder pain syndromes and triggers, irritable bowel pain triggers, hypertonic pelvic floor dysfunction as a trigger and as a result of all the other things is virtually 100% of people that have pain in the pelvic region are going to have pelvic floor dysfunction. Sometimes it's a primary issue, but most of the time, in my opinion, it's the muscles and the whole pelvic floor reacting to all of these other triggers. But it needs attention, and virtually 100% of my patients are directed towards pelvic floor physical therapy or generalized myofascial therapy, body-wide if they can find somebody. And some people can have internal pelvic floor physical therapy very easily because you can't touch their vaginas. And sometimes in the male patients, I have male patients who can't sit. Some of you may understand the term biker syndrome, long distance bike riders and motorcycle riders or straddle injuries, that sort of thing. Basically pudendal neuralgia, which goes into the whole thing that we're talking about here as well. So first is education, the sources of chronic pelvic pain. Again, they can be GYN, urologic, gastro, muscular, and neuropathic, and combinations of all of the above. So my program developed out of work done by others over at least the past 20 years. And I look back to the pioneers of pelvic pain and diagnosis and treatment. C. Paul Perry from Birmingham, Alabama was the force behind the International Pelvic Pain Society. During the 80s and 90s, he was doing many of the things that I showed you briefly on that one patient, and talking about neuropathies and localized peripheral blocks and all of the type of things that I'm doing now. He was doing in the 90s. He was a true pioneer. As we're, and here's an article. I forget if this is an article that I gave you. I don't think I did. But this is an article written by him, Peripheral Neuropathy and Pelvic Pain Diagnosis and Management. Back in 2001 was this article. So it was from work that he had been doing for the previous 10 or 15 years. Again, highlighting from those articles all of the nerves in the pelvis. Not all of the nerves, but he looked up closely at some of the major nerves. And then he was even talking back in 2001 about viscerosomatic convergence and referred pain, where signals come in from structural parts of your body and go into the spinal cord and not only go up to your brain, but can cross over in the spinal cord itself and go out to a visceral or organ part, and vice versa. One of the examples of that outside the pelvis is, why do we have left-sided arm pain with a heart attack? Everybody knows that that's a signal. If you're me at my age, or younger male or female these days, have left-sided chest pain and left arm pain and pain in the jaw, you head quickly to the cardiologist or the ER. But nobody ever asks, why does the left arm hurt? So you would think if the heart is blocked, if the coronary is blocked, and there's damage to the muscle of the heart itself, which is an organ, visceral, that your brain would say, something in my left chest hurts. But those signals go directly up to the brain, but also are diverted like this over into viscerosomatic convergence. And in that case, it generally goes down the left jaw and arm. So those concepts have been around for a couple of decades at least. So viscerosomatic convergence and pelvic fibromyalgia, basically IC, IBS, any of the gynecologic causes of pain, again, crossing over and going to the muscles of the pelvis and firing them off, same type of vicious cycle. And visceral hyperalgesia, crosstalk in terms of neuroscience, where the bladder affects the bowel affects the bladder, which affects the uterus, which affects the ovaries. All of the things are talking to each other. The two textbooks that came out on pelvic pain came out both about the same time in 2000, which is 16 years ago now. Dr. Stege from the University of North Carolina, Chapel Hill, and Dr. Dr. Fred Howard from the University of Rochester. Both of them also, along with Dr. Perry, were pioneers in starting the International Pelvic Pain Society. Unfortunately, neither of those textbooks ever were used widely at all, hardly at all, in any of the gynecologic or urologic or GI fellowships or training programs. The white textbook on the right is excellent. Much of the stuff I'm talking about today was in there about many of the non-gynecologic causes of pelvic pain as well, and it's out of print because they just couldn't sell it on. This is important. Dr. Stege that wrote the one book back later in 2008, a quote from him: maladaptive changes in the neurologic supply to pelvic organs may contribute to chronic pain to a greater extent than do stimuli from damaged tissue. Pain in gynecology may be treated in the future more commonly with neuromodulatory drugs, local anesthetics applied in novel ways, which we're talking about, and less invasive nerve stimulation procedures, all of which are basically non-surgical approaches to pain. Dr. Howard wrote in an article just in 2010 about IC, alerting gynecologists to IC and bladder pain issues. Basically, the paragraph under the heading says, don't overlook this IC when a patient complains of otherwise unexplained pelvic pain. As many as 85% of women who seek care for chronic pelvic pain have IC/painful bladder syndrome instead of or in addition to a gynecologic diagnosis, which is a pretty astounding figure. And I find that in my own practice, it's somewhere in the 70 to 80%. And many of those people are not coming in necessarily with bladder symptoms as a primary complaint. but the pelvic pain symptoms, and you do that PUF scale, which is a pain urgency frequency scale, and many other things. If you look at the total picture, the bladder is playing a part, even if it's a minor part, but it needs to be treated as well. ACOG, the American College of OBGYN, is catching up a little bit in 2014 with their most recent definition of chronic pelvic pain. Pain symptoms perceived to originate, the brain is saying, to originate from pelvic organs and structures lasting more than 6 months, which makes it chronic, often associated with negative cognitive, behavioral, sexual, and emotional consequences, as well as with symptoms suggestive of lower urinary tract, sexual, bowel, pelvic floor, myofascial, or gynecologic dysfunction. Kind of an overall look at it, but it's also, inside that statement is also triggers are going on here, and the other aspect is how those signals are being received here. And yet, in 2016, after all of the stuff I just told you, we still find that endometriosis, ovarian cysts, pelvic adhesions, and all the rest of that stuff, pure gynecologic, are commonly the first things diagnosed. An ad here for Lupron basically says that chronic pelvic pain is associated with endometriosis 71 to 87% of the time. And actually, a little bit of endometriosis in the back of the uterus through a scope. This is magnified. The bottom of the picture, the bowel, a little bit noticeable right here. And those two little black spots up there and over here are the endometriosis implants, and the uterus would be above. And this person probably had horrible pain with only those couple little dots. The problem is that people can have their pelvis loaded with endometriosis and never have one day of pain. So just seeing endometriosis and pain do not necessarily go together. I don't have time today to explain that further, but there are interesting research is going on at the NIH and elsewhere to try to figure out genetically, predisposition-wise, and mechanically and physiologically what's going on with those people who have very significant pain from this amount of endometriosis. In my opinion, much of it is yet unknown, but there's some good theories going on, but also the fact that a person with endometriosis, which is very common, the evil twins of pelvic pain are endometriosis and interstitial cystitis. And if you throw IBS in there, it's the evil triplets. You throw pelvic floor dysfunction, it's the evil quadruplets. You can go on and on. So we're not seeing much change over the decades with that poor young woman doubled over. And the same picture that the emergency room doctors always look at, saying, well, we've looked at everything in there and you're good. Nothing wrong with you. You're just hurting, so we'll give you an IV, little morphine, and we'll Dilaudid and Valium, or whatever it is. You're on your way until the next time you come back to the emergency room. Not associated with your period, but just out of the blue, seemingly random. And also can't sit, and also can't have sex, or being inflamed, or just having dysfunction. And those signals go into the spinal cord and presumably go up to the brain with what are called generators, neurotransmitters. We're talking about dopamine, we're talking about serotonin, we're talking about norepinephrine, we're talking about adrenaline, all of these chemicals that you hear about when you hear about pain and pain processing. And immediately, there's supposed to be inhibitors that come back down to balance those signals going up from whatever damage has been done down here. So if you get stabbed with a knife anywhere in your body, the signal will go up. And your brain says, should I pay attention to this? I'm going to throw down a bunch of inhibitors, and oh, it still hurts. I don't have enough inhibitors, and through all my previous experience, that feels like something sharp. That feels like something that I need to pay attention to. But you all know that sometimes you can have a pretty bad thing happen to you. About 3 or 4 years ago in the basketball court in the playoffs in March Madness, there was a young man who fell and his bone was sticking out of his leg. Some of you may recall that because it was all over TV, it was live TV. And 2 days later he was interviewed and said, after he had a surgery, because they interviewed him because everybody in the country saw this horrible thing. And he said, you know, I was laying there and I was saying to the coach, why is everybody so upset? I just want to get up and run it off. I just twisted my ankle. Okay, so his adrenaline, his inhibitors were way up, and he did not feel a bone sticking out of his leg. If he had looked at it, he probably would have been a little upset too. Okay, so you compare that to the other end of the spectrum, where somebody has no foot, and still comes in and says, my foot is on fire, which phantom limb pain can be the most excruciating pain there is. How does that work? I don't have time to explain all that to you today, but I can tell you that I knew nothing about any of those things as a gynecologist, and it's been a 15-year process to start to try to understand how that all fits in. So, this seems to be a good balance, okay? If you stub your toe, or if you have a menstrual cramp, or if you have a little bowel cramp like we all have from time to time, or any other little sensation, and you know that it, by experience, that's not a knife sticking into your arm, you move on because the inhibitors and the generators send a balanced signal that says, this is not dangerous to me at this moment, I can move on. Okay, so that's a balance that was just like a diabetic. 150 years ago, before they knew diabetes existed, they didn't know blood sugar up here and down here. They just saw people sometimes having convulsions and sometimes going into ketoacidosis and looking like they're dying, and they were. And it had to be in their head because they didn't have a measure or any idea that their blood sugar was involved with how they were presenting themselves. Today, we're just starting like the beginning of understanding that pain is an imbalance, as well as anxiety, as well as all the other emotions that come from having the pain and experiencing the pain. And if you're told over and over that it's going to go on forever, and it seems to go on forever, then what happens at some point, chronic pain starts to be the issue. So the generators then outweigh the inhibitors, and as if there's a volume dial in the nervous system. And this is the thing that really hit me when I heard this at this talk. It's Dr. Daniel Clow, C-L-A-U-W, from the University of Michigan. You can actually see him on YouTube, gives talks about these kinds of issues, and others. If you look into YouTube, remember I said online there's some really good things you can find. This is one of them. So I show all of my patients the fact that their dial is up. Chronic pain is central and peripheral sensitization, which the science of neuroscience and how all this is processed, that's the main thing that has been looked at over the last 10, 20 years. What is in all those journals of pain, of research? A lot of how all of this actually happens. And we're just starting to understand it. We are just starting to. I do no research, but I think it's astounding how the tools of understanding this thing have exploded, and we're learning more and more. And we should, as clinicians, understand it more, because everyone sees people in chronic pain, in whatever specialty you're talking about. So, the terms neuromodulation, central sensitization, peripheral neuropathies, wind-up, which is that wind-up of the volume dial, neuroplasticity, which is a concept that didn't exist 20, 25 years ago, showing that nerve injury, nerve trauma, central nervous system issues that seemingly were permanent and could not regenerate themselves, now is known that we have plasticity of the nervous system, and you can reboot the dial down. Okay, it is possible to do that. And that's what we aim at in our clinical program. In our case, limiting our attention to the pelvic region. But because we train people so well, and take so much time with people to understand these issues, many people start to understand why they have menstrual migraines, why they have a whole bunch of other issues that have been bugging them, and going to low back pain docs and so forth. So I think we're educating people about their whole system, not just their pelvis. So Dr. Klaus is he's a professor of anesthesiology, rheumatology, and psychiatry. He's boarded in all three and is director of chronic pain and fatigue research center at the University of Michigan. That's who I quoted a minute ago. So he basically, and others, the current paradigms for diagnosing and treating chronic pain. The current diagnosis and treatment is based on antiquated views of pain mechanisms. So the chronic pain may be a disease in itself and is not simply acute pain that has lasted too long. I'm sorry, I went backwards there a little bit. So we have to look at chronic pain as a different pathophysiology, not just acute pain that goes away after the injury is healed, but goes on and on and on, unfortunately. Also, that there is no chronic pain state where there is a good relationship between the degree of damage or inflammation in the periphery and the amount of pain a person is experiencing. That's the disconnect between, as a patient, talking to a doctor and being sent for all those tests, because almost all those tests are going to show almost nothing. But you can't see the pain. You can't see the nervous system, what's going on with that dial. So it looks like the patient is reporting an exaggerated version of what your tests are showing. Until recently, many assumed that when there was a disparity between peripheral findings and pain, this was due to psychological factors for obvious reasons, and now it's clear that there are a multitude of central neurobiological factors that can increase or decrease sensitivity to pain. And he also talked about all of the other multiple chemical sensitivities, chronic fatigue, sleep disturbances. Down here, IC, female urethral syndrome, vulvar vestibulitis, TMJ, all those things are interconnected, as probably many of you realize. The Australian connection, I highly recommend going on, and if you don't get this down right now, but YouTubing these guys. Looks like children's books, but trust me, they're not, in explaining pain. And the books that I've been very helpful with as far as telling people about are The Body Bears the Burden, The Body Trauma Dissociation of Disease, and The Body Remembers. One's written by a trauma specialist from Colorado, actually, and the other is an MD, and the other is written by a psychologist, but basically talking about the neuroscience involved with PTSD and all of the cumulative injuries that add up to what you see in front of you at a given time. So we have all the somatic nerves, meaning all the nerves that are coming from the central nervous system out to the abdomen and pelvis, and the visceral nerves that are going to all the organs. This is, when I said about the heart and the left arm, any sensation from IC that makes you aware that your bladder is causing pain, or your uterus is causing pain, or your prostate is causing pain, or your bowel is causing pain, all go into sacral 2, 3, and 4 right in the tailbone. And those nerves go up, those sensations, those signals go up to the brain and say, I got a pee, I got a poop, I have a period coming on, I have a labor pain, whatever. But also, they can be diverted over to the nerve that's coming down through the butt on each side, called the pudendal nerve. And that innervates, when that dial goes up, it innervates the entire lower genital tract, the whole saddle area. So you have all these nerves, abdominal and pelvic nerves coming down. I'm not going to go into the names of all of them, but the ilioinguinal nerve block, when somebody in the room here says that they were sent by, I think, Dr. Garrett down to a doctor in Washington to have minimally invasive surgery on the ilioinguinal nerves. I met him a number of years ago, and he's close to where we are in Pennsylvania. so when these nerve blocks don't work in the areas that I'm talking about here over time, by desensitizing the peripheral sensitivities, occasionally I will send people to him as well. Trigger points, the physical therapists in here, and those of you who have had physical therapy, all of the trigger points that you can find very, very easily from my standpoint, because I examine people purposefully to find those trigger points. But the trigger point means you're triggering something that can affect those entire areas. So we have a lot of people that I'm taking care of now posteriorly with the treatment that we do. The piriformis muscle that many of you understand can cause a lot of problems that go down to the backside and go to the perirectal area, the perineum. I'm injecting just small amounts of anesthetic into those areas, and people are able to sit up and say, oh my gosh, I can sit on my butt for the first time in a long time. It's a very complicated area structurally, but in the end, there's only a few basic spots to check on a regular basis when people have these issues. So piriformis, sciatic knots, and SI joint trigger points. As you see here, I'm going to go a little more quickly here. Anococcygeal nerves right next to the junction of the sacrum and the coccygeal area. Again, for the physical therapist and for those of you who've gone to physical therapy, it's not a surprise, but all of the muscles in the pelvic floor and inside the pelvis, you can have all these reasons for the core of those muscles clenching. Athletic training and core strengthening, dysfunctional pelvic organ disorders, conscious trauma leading to fight or flight response, unconscious trauma, surgeries, childbirth, cumulative small events over many years, upregulation of the central and peripheral nervous system with the bowel going up, and then those muscles. I'll show you that picture again here. So myofascial and/or for physical therapy is crucial in the multidiscipline approach. Again, in the upper left picture, do you see any muscle in there? And I asked the patient just last week, and she said, yeah, here's muscle. She's right. She's right. That's the pelvic floor, but who would see that? And this is actually what a real body looks like, cutting right across here and looking straight down. You see the vertebra, the pubic bone in the front, and the entire pelvis is loaded with muscles. The bladder would be right here, the uterus, ovaries, and/or prostate, and then the bowel coming down into this area, tucked in to a tiny little area surrounded by muscles and nerves and ligaments. And that's a revelation to almost all the patients when I show them these pictures. I got it. Shut, yeah. So I'm going to try to finish up in 2 minutes here. Warrior Girls is a good book to read for those of you who are interested in seeing what cumulative trauma through some of the sports in young women from all these sports, just like Karen was mentioning, even up to the Olympic level. Some of the are telling young girls to man up and stretch it out and play through the pain, and then they read those messages into their later life and learn to live life through pain and even have sex through the pain. And he had all these cumulative physical traumas, surgical, obstetric traumas, emotional and sexual abuses directly against women. You can see why there's such a high prevalence. Most doctors are not familiar then in the whole area of the perineum and vulvar area with the bowel going up and all of the nerves there. And just a couple quick slides here to show simply on the bottom right here how you can actually feel the ischial spine, which is where the pudendal nerve comes out. You can do a pudendal block right in an office, which I do, and not necessarily under imaging, right in that spot, right there, and examining for pudendal neuralgia and doing a block right there. That looks pretty bad to have a needle put there, obviously, but people come back and come back and come back, including a 32-year-old man who I also do blocks in the same location, who was a motorcycle cop. And even after 3 or 4 blocks over a few months, all of his pain was gone. He also had ejaculatory pain and erectile pain, And all of it was better. He said, I want those blocks for another 3 months because I do not want that to come back. And then I stopped seeing them, and they never came back again. I said, you don't really need them, but he wanted them. So checking for the vestibular area, I'm just going to show the ways in which, I'm sure some of you have been examined like this. The area around the opening of the vagina, which is totally different skin than the external hair-bearing skin and the vaginal lining. There's a little area of redness at the vaginal opening. Sometimes just a tiny little area as big as my fingernail can be the spot where people will say, that is where I can't be touched. And we do a Q-tip there, and they almost go off the table. It feels like a knife or a hot poker sometimes. Here's somebody with advanced lichen sclerosis, but she's 75 or 80 years old, where all of the tissue has kind of fused together. No pain at all, never had pain, but advanced lichen sclerosis. Here's another person that has the labia and the inner lips and the outer lips kind of fusing, and you see all the real red stuff. That's the vestibule, and then the lichens is starting to mess up her anatomy on the outside. This is a 22-year-old, and you can see how the inflammatory nature of lichen sclerosis, which is an autoimmune skin condition, blends into vestibulitis and makes it very difficult. Many of these people are biopsied, and I was talking a little bit to Dirk before about people getting biopsied here and having all kinds of chronic inflammation, and sometimes precancerous lesions in that area. So it's a very important area to follow and for patients to know about. And checking the bladder, instead of doing a bing, bing, bing kind of exam as a gynecologist, I had to learn how to gently do a bladder check first. And even in men, checking right in this area here, which is where the urethra is located after it comes to the prostate, for helping in diagnosing the frequency, urgency, and tender urethra in that spot, which is why they're having trouble sitting. When I examine people that way, I'm told that the urologists have never examined that spot ever, and they've gone to, say, 5 different urologists. So I got to finish up here. Bladder installation treatments, and that's it. It's not in your head, even though it feels like you're a train wreck. And okay, pretty much all the same thing again. I'm going to go into this later if I have time. Persistent female. If I can turn this off. Okay. Thank you.